Hey everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live. I am your host, Dr. Shirin Towfigh, your hernia and laparoscopic surgery specialist. Thanks for everyone for joining me. We are live as a Facebook Live and also on Zoom. You can find me on Facebook at Dr. Towfigh. And for those of you that would like to follow me on the other social media platforms, we've got Instagram and X at HerniaTalk. As always, this episode and all prior episodes, and we're getting close to 200, so that's like really cool. They will all be available to you, are all available to you on my YouTube channel at HerniaTalk. And if you like podcasts like I do, or I listen to podcasts when I'm driving, we're also a podcast. So you can find me as a Hernia Talk Live wherever you listen to podcasts. So I'm super excited today because I get to meet, and you all to meet, Dr. James Wyss. He is a physical medicine and rehabilitation specialist. You will learn all about what that means and how that can help you. He works at the Hospital for Special Surgery. We'll learn more about this very special hospital in New York. And I'd like you to welcome Dr. James Wyss. You can find him on Instagram at Dr. James Wyss. Hi.
How are you? Thanks for having me.
I'm good. Thank you. Are you at work still?
I am.
Oh my Lord.
Because I have a new puppy at home, and that's our third dog, and the house is full as is, so it
okay.
would not have worked. So I purposely planned it this way.
Thank you. Because of the podcast needs, you stayed at work just for me. Because
Just for you, absolutely.
It's 7:30 at night.
Yeah,
I'm
I know.
sorry.
I know. That's right. I'll head home after this.
Well,
And the last name's pronounced Wyss, by the way.
Wyss. I
It should
apologize.
be Wyss or Weiss, but it's pronounced Wyss.
You're mispronouncing your own last
I
name.
mispronounce. Whole family has been for a long time.
Well, it's a pleasure to meet you. We share patients, and that's why I got to meet you, and that's why I reached out to you, because I have a lot of friends and colleagues who work in New York that do similar practice than I do, hernia surgery almost exclusively. There are a handful in New York. They're all really, really good. They've all been past guests of mine. And I said, I need someone who can help me with X, Y, and Z, and your name came up. So I appreciate you accepting to be a guest on the show.
You got it. I think it was Dr. Mark Zolan who
Yes.
connected us, and Mark's been wonderful learning from him and sharing patients with him. So happy to be here.
Thank you very much. And he was a great guest a couple years ago, I think he was. So thank you. So my very good friend from high school is my physical medicine and rehab specialist. And I don't even know how he knew to be PM&R, or
Yeah.
physiatrist.
Yep.
I was never exposed to that specialty in medical school. So maybe you can explain a little bit for our audience, which is mostly patients.
Yeah.
How did you even learn about PM&R, and what do you do?
And to add confusion, internationally, it's PRM, which is physical and rehabilitative medicine, which actually probably makes more sense. But
okay, well, we have a very international audience, actually, so thanks for clarifying.
All right, wonderful. Yeah, so and there is a strong international presence in my specialty. So this is my second career. I was a physical therapist first, and so I was one of the rare, and I sought out a job towards the end of my career as a PT, working with a physiatrist, which is the other name for a physical medicine and rehabilitation doc. And so I had kind of on the job training and an opportunity to see if that might be what I want my career to look like. And so, yeah, I was one of the rare people, probably the only one in my class who went into medical school pursuing this career. I almost deviated from it because one of my loves is sports medicine. So, and I loved the idea of family practice, but I kind of stuck with the plan, and here I am today.
So you went to college, finished medical school, and then applied for the PM&R residency. And how long is that?
So we typically do an internship, 1 year in medicine. Some do an intern year in surgery, but most do a year in medicine. And then there's 3 years of residency for PM&R. The first year is heavy in a lot of inpatient rehabilitation care. So a lot of more neurorehabilitation, some multi-trauma, but a lot of spinal cord injury, brain injury. That's a big part of the roots of the care we provide. And so having a year in medicine is really helpful for that, because you kind of feel at first like an intern in a rehabilitation hospital. And then the next 2 years dive a little more into the specialty, which is pretty broad, which can
Very
be
broad, yeah.
right, which can be rotations in burn care, outpatient orthopedic type care, can be more electrodiagnostic work. So a lot of our field overlaps with a lot of the other medical specialties, as with time it does for all of us.
And some of you work more on the orthopedic side, others more on like the spine side, right? And some do pain
Correct.
management.
Yeah, my practice is a little blend, because I take care of a lot of athletes with spine conditions, and then I
Got it.
do a lot of what lots of people refer to as sports and musculoskeletal care. So it's a lot of work on the extremities, so a lot of knee and shoulder and hip care. And further down on the extremities, but and then some people just kind of fall into a path of more pain management and interventional spine care, and they may not do a lot of sports or peripheral extremity work. Yeah, and then there's a whole other side of my specialty, which some might call more rehabilitative medicine than physical medicine, which is really a lot of that kind of inpatient care that I referred to as well, and the post-recovery from life-changing injuries and events like a spinal cord injury.
So when would someone come to you as opposed to your prior career, which was being a physical therapist?
And there's a lot of overlap there.
Yeah.
In certain states, when there's direct access to physical therapy, a lot of the problems that people might seek me out for, they may see a physical therapist first. They're experiencing low back pain, they injured their knee, but they don't think it's too serious, shoulder injury. So a lot of those problems do go direct access to physical therapy. And I think it's really, it's kind of rules within the state, but it's also patient preference. And I think patients are still seeking out more, if they can, physician-directed care at first.
Sure, because you can prescribe certain things that a physical therapist can't prescribe, right?
Right. Ordering tests, there's limitations on the PT license. That's a whole separate topic, because I can kind of talk on both sides of it. And
it's a lot of overlap. And
yeah,
I guess
yeah.
some PM&Rs focus, because there's so much overlap, they kind of end up focusing on something. And then if someone doesn't need surgery, when would they choose you as opposed to an orthopedic surgeon?
So in a hospital like Hospital for Special Surgery, ideally the kind of pathway we'd like to guide patients on is to be evaluated by a non-operative or a non-surgical specialist first. And then if it's severe enough, or there's a clear surgical indication, the referral goes from me or one of my colleagues in physiatry or primary sports medicine, and then goes on to orthopedic surgery. That would be the ideal model, but often there's not enough of us on the front line, so some of it is a little random, I think. And
there's really not much
that you have, and who you know, and who you get referred to.
Yeah, there's really not that much. There aren't that many. And your names are weird because it's PM&R, because it's hard to say physical medicine rehabilitation, but then physiatrist, I don't know when that term came about. That threw me for a loop, because it sounds like physicist and psychiatrist. I mean, I'm sure you do all of that anyway.
And there have been debates about, is it physiatrist with an I or physiatrist with two E's in terms of how you would phonetically pronounce it. But I basically tell my patients, first of all, I'm appreciative if they do a little homework and have taken the time to understand my specialty, not just me and my career, but my specialty in general. But you know, if not, I just take a moment to explain it to them and let them know it's not a household name, and I don't know if it will ever be. But certainly you kind of allude to it. We fill gaps in different areas
So much.
of medicine and in the surgical realms as well.
Well, my physiatrist, I mean, he's very intelligent, and I think um the beauty of your specialty is you really understand the body so much and how everything interacts. You know, orthopedics kind of has their own, they're like joints and bones and
Hmm.
muscles, but um I mean, I guess they should be into function, but it's very much more a mechanical thing. And
Hmm.
then you got the physical therapists who are excellent, by the way. I'm sure Mark has told you what I keep saying, which is I actually get quite a number of referrals from physical therapists because they are so good in actually hand-on patient, feeling where it's abnormal, where it's not, where there's spasm, where there's not, and
Yep.
bringing it down to muscle groups. People come, for example, with groin pain, which we'll
Yep.
discuss more in detail, and they've had like endoscopy, colonoscopy, and I'm like, how how is that causing groin pain? But they see GI doc, right? Because it's abdominal pain, but
Yeah.
it's really the groin, and they get pushed to this, and then they get pushed into this other like urology, gynecology, and it's the
Hmm.
physical therapist that says, I think this may be a hernia because they're really the ones that do a really good exam, and their fingers are like really sensitive
Yes.
to know what's wrong.
Yeah, I always tell my patients or other colleagues that I did not learn my physical examination skills in medical school, unfortunately. I had
Yeah,
good
yeah.
mentors along the way who showed me things, you know, right in at the bedside in the clinic, but I really trained my hands as a physical therapist. I mean, just not just the evaluation, but a lot of the treatments you provide are hands-on and
Mm-hmm.
observation with a little hand on that body part. And it just trains your hands in ways that we don't get in medical school.
So
I
interesting.
didn't go down a surgical path. I do a lot of interventions, but that using needles and fluoroscopy and ultrasound did not train my hands the way that I think
Yeah, yeah.
learning palpatory skills in physical therapy school did.
Plus, I think in the United States, we don't stress physical exam as much. We have a lot of like get a CAT scan, get an injection. It's a lot of like studies and tests as
Right.
opposed to physically putting your hand and being like, yep, based on this exam, this is what you have. Yeah, it's
Less
very
time
true.
with our patients, right?
Yeah, so
You
true.
know, so
So true.
quicker sometimes to order a test, but not as helpful. I always say, hey, we're treating you, not your pictures or your report or anything like
Yeah.
that. That's hard.
A lot of patients that I see, like the doctor never touched me, never examined me. And it's like, you clearly have the hernia. Yeah,
Right.
I never
I
examined
was
you.
shocked the few times I heard that at first, and then I just realized, okay, this
It's
is
a
part of
thing.
what's going on out there in practice.
Yeah, yeah, it's a thing. Do you work out exclusively at the hospital?
I do.
Okay.
So I currently I'm in our Long Island office. We have a big satellite in Nassau County on Long Island. We have satellite locations in Connecticut, Westchester, New Jersey, Florida as well. So
Oh,
we've grown a bit. Initially, a lot of my work was on the main campus, and now I spend more of it because family reasons and different things on Long Island.
and hospital for special surgery is a very elite hospital, very highly specialized. Can you explain what a patient would expect to get their
Yeah,
treatment in there?
I mean, most people compare it because our neighbor is Memorial Sloan Kettering, so you know they kind of understand. They've maybe had themselves or a loved one or you know a friend has had some care at that hospital, and
Hmm.
so they often relate it like, oh, this is a specialty hospital, like they specialize in cancer there, you guys specialize in orthopedics there, and
Yeah.
yeah, and you know, long history, I think over 150 years. I hope I'm not
Wow.
misquoting anything that you know, really has grown into, you know, a really leader in orthopedic care and education. And really with time, I think has grown in a way where we're looking to provide a continuum of care in musculoskeletal care, not just that referral for complicated orthopedic surgeries that maybe failed elsewhere and coming there. That may have been some of the
Right.
root was built on, but now it's being built into a continuum of musculoskeletal care, which fits why I even went to medical school and why I remain at the hospital.
Sounds like a perfect fit. So, as you may know, this is a live show, and therefore we encourage our audience to turn in questions either before or during. So there may be questions that are coming in. I have a couple of questions already that have been posted to me by some of our international viewers because they can't watch live. The hours are a little bit wrong. Um, which will be nice. We'll get through those. But one of the main reasons I want to talk to you, because you have the physical therapy, orthopedic, um, and a little bit of general surgery kind of bent to your practice. Uh, Groin pain is complicated, right? So in men, it's a little bit easier. In women, you add the whole gynecologic reasons for groin pain. But people who come to my office, I have to figure out, even if they have a hernia, right? Some of them have hernias. One of the problems I see are people that have hernias, but the hernia is not the cause of their pain. So they get their hernia fixed. And not only did it not affect, treat their underlying cause, now they have a complication from the hernia repair that they never really needed. So the patients are, at a loss, and the surgeon says, I did a perfectly good hernia repair. And as general surgeons, we're not really well taught about all the different pelvic anomalies that can happen. So my role is often to figure out, is it gynecologic, urologic, orthopedic, nerve related? Could it be like a muscle tear or something?
Right.
And so on. So do you have any good ways of figuring out, like, what are key questions or key activities that can kind of help differentiate all these different
Yeah.
reasons for groin pain?
I immediately, which is the opposite of what I do, I immediately kind of think about my physical examination.
Mm-hmm.
I spend most of my time every day, like you probably do, listening to my patient. And, a lot comes out of that. But when it's someone who is, and like you mentioned, the case of someone who had a surgery done that didn't fix the problem, even if they didn't have a complication, there's an added layer of frustration. And now there's added issues of chronicity there. And that just makes it harder to treat. But so many times with this, I do really have to depend on my physical exam. And fortunately for my work, it's kind of straightforward because a patient should be able to localize their symptoms to some extent. So we often say, can you point with one finger to kind of the epicenter of this all? And then you can show me if it radiates or spreads out or however, but can you kind of localize where you think that's starting from? And then I should be able to either put a stress with some sort of passive stretch on that tissue or that bony attachment. I should be able to ask them to try to perform a maneuver that contracts that muscle. And then I should be able to palpate that. I personally save palpation for the end because I find if I go palpating around during the early part of my physical examination, I may have aggravated everything. And now every test I do after that seems symptomatic. So I listen enough to take me down a certain path of what I think I'm going to find. And then that issue, like for example, if I think they have a misdiagnosed proximal hamstring tendinopathy or a partial tear of the not hamstring, I'm sorry, adductor, I might strength test into adduction and passive stretch the hip into abduction last, and then palpate that structure last, just so that I throw off the exam. So I have to mechanically find the source, and that makes some of what I do a little more straightforward than probably the dilemma you're often faced with.
So that falls into the realm of like sports injuries.
Mm-hmm.
And, we use the term sports hernia, which is,
Mm-hmm.
it's not a hernia, but it's a
Right.
sports injury, which includes, correct me if I'm wrong,
Mm-hmm.
the way I explain to my patients is the rectus muscle inserts on the bone, you can tear that.
Mm-hmm.
The adductor muscle, which, allows you to walk and go upstairs and push
Mm-hmm.
the thighs in,
Yeah.
um, kick a soccer ball or whatever.
Right.
That also inserts on the bone, you can tear that.
Mm-hmm.
You can have a tear of your fascia in the groin area, like
Mm-hmm.
of the external oblique. You
Yeah.
can actually tear that.
Mm-hmm.
Sometimes you tear it right over the nerve, and then the nerve gets irritated because it keeps getting pushed into this tear. So
Yeah.
you can have like nerve type pain from that.
Mm-hmm.
Um, and then you can kind of shear or shred some of the deeper muscles in the groin,
Yeah.
Gilmore's hernia, whatever. Uh, those are not hernias, but they can all cause what people call groin pain.
Right.
And a lot of times, like the tears in the muscles, some of them that you can see on imaging, but what's the frequency that radiology will help you with some of the
Yeah.
mild to moderate problems?
Yeah. I mean, I think that's improved a lot.
Okay.
Um, And Mark Zolan's been a big part of that. Even though he's not HSS now, um, he has a strong affiliation, I think, has privileges at our hospital. But
Mm-hmm.
some of our work with him, I think, has been very helpful to put together an athletic pubalgia protocol for the
Yeah.
MRI, because lots of times you were just doing a typical coronal MRI and it was not lined up for the pubic bone or the
Yes.
attachment. And so, I used to see a lot early in my practice, and that's, I've been at the hospital since 2010. So that doesn't go way, way back. But I would get a lot more cases that were called osteitis pubis because you
Yes.
just saw on the fat suppressed images, you were getting that the pubic bones were all lit up. But then when you got the right images, you saw that there were anatomical reasons for it. This wasn't a stress fracture. This wasn't related to maybe metabolic issues. There was an anatomical problem, an injury, either with those muscle attachments you described, or what some people refer to as the aponeurotic plate on top of the pubic bone. And so we started to see that better. And once we did, then I started integrating ultrasound at the bedside a little into my practice.
Mm.
Sometimes you just saw the bone looked a little more irregular on the side of the symptoms. And that went along with the exam and the MRI, and everything started to come together better with time, I
So
think.
is that because the bone, when the muscle attach or the fascia attaches onto the bone,
Mm-hmm.
every time it's like NFL football players I've seen,
Mm-hmm.
they have
Yep.
horrendous bones because it seems like over time the muscles constantly pulling, these humongous muscles
Right.
are
Right.
pulling off of the bone and kind of like it's like pulling your hair out, right? It's like
Yeah.
pulling
Yeah.
on the
Totally.
bone and you get these spicules,
Right.
whereas it should be like a smooth bone. You have these areas where the bone keeps getting lifted off of its natural
100%.
position. Is
Yeah,
that what
and
it is?
right, and absolutely, we call those, cortical irregularities if you're looking
Mm-hmm.
under ultrasound, and it looks like that. It goes from it being a smooth bone to spicules and rough
Okay.
areas of it. And it does many times correlate well, as long as your exam again is going along with it. And fortunately, that's the same thing we see for all the other muscle attachment problems. So all the
Okay.
tendon issues, we see the same changes at the heel bone on the calcaneus when someone has a bad Achilles tendonitis. We
Mm.
see, I pick any tendon and you see those, the rotator cuff on the greater Jurasi. We see these changes the longer some sort of tendon related problem is happening. And it's not a bone problem, it's a
Right.
soft tissue attachment problem.
Got it. And so for if it's a true hernia, right?
Mhm. Mhm.
They can have pain at the groin and then
Mhm.
it can radiate. Some patients it radiates around to their lower back. Some
Mhm.
people it radiates to the inner thigh, even to the testicle.
Mhm.
Can you see that with sports type or athletic pubalgia or sports or groin pain?
I think you can, but usually when I have it's rare that I find a pretty clear cut case of sports hernia.
Mm-hmm.
And I also see a large symptomatic hernia.
Mm-hmm.
It seems like we many times see these small hernias that the radiologist points out to me, a little fat trap somewhere. So see those a lot. Um, but uh, but yeah, when I think, and I might be seeing a subset of the population where
Yeah.
it's almost been weeded out by the time they get to me that this is more likely orthopedic in nature.
Yeah.
But I don't get as much confusion with that.
So hip disorders also give groin pain.
Yes.
And the way I explain to the patients is if you actually look at an anatomy skeleton, the true
Mhm.
hip joint is not where people point to it
Right.
outside.
Right.
Here's my hip. It's
Yes.
actually further in, which
Mhm.
more aligns with where the groin is just in a deeper plane.
Yes.
Um, do you what how do you help differentiate from their history, let's say, a
Yeah.
hip disorder versus a groin or hernia
Yeah,
disorder?
yeah. No, that's a great question. It's easier in someone typically over 50 who's developing some osteoarthritis of the hip joint
Mm-hmm.
because they'll notice a change in their walking, or sometimes it's a friend or a partner, spouse who will notice, yeah, he walks different over the past couple of
Mm-hmm.
years.
And that's not
Um,
normal for hernias. Hernias don't affect your gait.
right,
Yeah.
right. From what I understand, that's 100% true, I think.
Yeah.
And then they'll also talk about difficulty with shoes and socks. They're doing some creative things to get their
Mm,
socks on, whereas they used to be able to put their foot up on the other leg and just throw, whether they were standing or sitting, they could just throw that sock on, throw that shoe on. And now they're talking about, oh, I put the other one on first and then I do this. And so that's pretty classic, difficulty with shoes and socks. Getting in and out of a car or public transportation. It's that transition when people get stuck. I often tell my patients, they say, why does the problem, if they know it's their hip joint, feel better if I've been moving for a while rather than when I get up? I say, well, motion's kind of lotion for the joint. And we say, I'll move that. But
that's a good
but
one.
the best time I look for hip problems or an altered walk is after they've been sitting waiting for me to see them a little bit. We'll go through our history and I'll say, the first thing I want you to do is take a few steps out into the hall, and they'll have an abnormal walk and then it corrects a bit as they're in the hall. So these are kind of classic hip joint problems.
Uh-huh.
And again, easier to identify in the crowd that's kind of over 50. It's the pre-arthritic conditions in 20, 30-year-olds. I work with a lot of college athletes.
Mm-hmm.
So I'm a medical director at St. John's University, and that group's harder to figure out the hip joint pain because sometimes they're fine with all their everyday activities.
Right.
Really only sporting activities that then produce it, which that's more challenging.
Got it. Yeah, I feel like they tend to wear, they like softer shoes, if
Mhm.
they got hip problems. And when they sleep, they like to put their like pillow under their knee, whereas for hernias, people
Yeah,
don't
interesting.
necessarily need to have like a tabletop position for their
Man, that
and
makes
like
sense.
if they have a FAI, like a femoral
Yeah.
acetabular impingement or something.
And I do
Also,
think the physical exam is really helpful in that group as well.
okay,
Because if I have somebody completely well supported on the table, and now I support their thigh and guide them through some motions where I'm really trying to just isolate movements of the hip, and
yeah,
that aggravates it, it shouldn't be anything else. It shouldn't be a hernia that you might often see. It shouldn't even be a sports hernia because it's just passive movements of the hip joint that's actually reproducing their same pain.
got
That
it,
should be ball and socket pain.
got it. And lying flat shouldn't make your hip pain go away, whereas lying flat usually makes the hernia pain better.
Interesting.
Hmm.
Okay.
The other thing I noticed is people with hip disorders have like a buttock pain as opposed in addition to their groin pain, but you don't get buttock pain with groin
Makes sense.
pain due to hernias.
And I think a lot of that buttock pain, because back of the hip pain is the least common location of pain when it's in the hip joint. It can happen, but what also commonly happens is if the hip's not functioning well, the back gets thrown off a bit. If your walking's not right for a certain period of time, or your sporting movements have changed to compensate for hip joint pain, you're going to move different through the rest of the pelvis and the lower spine. And so that butt pain sometimes is the development of some secondary lower back or posterior pelvic pain.
Got it. Here's a question. It says, Dr. Wyss mentioned osteoarthritic changes of the hip as a marker. Does isolated labral thinning have the same significance, or is this so common in the elderly that it is not diagnostic?
The latter. We all
Elderly
have,
common.
and even at young ages, we have changes of our labrum. There have been some good studies on like military recruits going through boot camp who get screened for they have no current or pre-existing hip pain, and they have an MRI done and they have abnormalities of the labrum quite commonly. So then the wear and tear, the thinning, those to me are more common with just activity related and age acquired changes to the joint.
That's
On
interesting.
occasion, they can be symptomatic, but the majority of the time it's the latter, that it's just a normal change to the joint.
Yeah, I see a lot of people who get hip MRIs or pelvic MRIs, and it mentions, femoral acetabular impingement, or rephrase that. It mentions labral tear,
Yes.
and they see a orthopedic surgeon, and the orthopedic surgeon says, "Oh yeah, there's tons of people that have labral tear on imaging, but it's not the reason for your pain." Is there a way to tell whether a labral tear is a cause of pain or something else is a cause of groin pain?
So mainly then the physical examination to see
Okay.
if you can provoke pain from the hip joint. If we're still not certain, that's when we'll perform a hip joint injection, which can be done under fluoroscopy, under X-ray guidance, or under ultrasound guidance. Nowadays, the majority of them are performed under ultrasound guidance. And that's interesting for what you mentioned in terms of the location of the hip joint. So
Yes.
we do those through the front anteriorly, and many times people are surprised we're not doing them from the side. And
Yeah.
then when they realize where the needle went, they say, "Oh, that was pretty close to where I feel my pain." So even
Got it.
just that part of that procedure can help enlighten.
I'm told when you do the injection, you include, well, let me rephrase this. For pain, when you do the injection, it involves local anesthetic. Is that correct?
Correct.
And then I'm told when you do MR arthrograms or any type of arthrogram, like X-ray that wants to look at the joint, and they inject the contrast, they also include the anesthetic in the contrast. So sometimes besides it just being an injection for the contrast so you can look at the imaging, it can be somewhat diagnostic too, because if your pain goes away,
It could
it's
be.
from that. Is that true? Does everyone do
It's
that?
true, except the majority do now at HSS. We do not perform any arthrograms. So
Oh,
yes,
because
our
you're
head of
that good.
radiology, right. So Dr. Hollis Potter has done some wonderful work where we think we can see everything we need to see without contrast eye. And
Fantastic.
I think that's true in 99% of the
Wow.
cases. Yeah. The problem I see a lot, since I'm out here practicing on Long Island, we have a presence on the island, but there's also a lot of other healthcare systems providing care. So I see
Sure.
plenty of patients who come in with arthrograms of the hip that were done. And yes, that's a common practice. The contrast eye with the anesthetics. Problem is you're diluting everything. You're also filling up the hip a lot. So sometimes your patient has a difficult time. The injection soreness, the volume that was put in the hip, and did that anesthetic really help? Which is very different than if I want to do an anesthetic, a diagnostic injection, or one of the surgeons I work with orders it, I could do a real low volume injection and examine them before and after and really help them to understand if that really made a difference
Okay.
in what they were feeling. So that I find that to be more helpful.
Yeah, we have a hernia protocol MRI, and one of the radiology groups that offers our protocol, which is a Valsalva based
Mhm.
pelvic MRI of the soft tissues, looking for little groin hernias, etc. They also give me some good shots of the hip, which
Yeah.
is great because, it's
Yeah.
if I'm looking for that small of a hernia, there may be another diagnosis that I'm missing, which more likely will be
Yeah.
a hip related. So it's kind of nice that they do that. I think because they're musculoskeletal radiologists, so
Mhm.
they enjoy like take a little look at the hip and it gets some a good information
Yeah,
there.
I mean, when you get that coronal, that front of the view of the pelvis, I mean, you're seeing hip joint, you're seeing lower lumbar
Yeah,
spine,
yeah,
sacroiliac
pelvic
joint.
floor, everything.
You right, you get a lot that you can look at.
Yeah,
Yeah,
it's a great
yeah.
protocol. It's available on the website for anyone. We often give it to our patients to take to the radiologist to
Mhm.
if they're from out of state to see if they can reproduce that
Got
protocol.
it.
Um,
And I have had patients who later on followed up with me for other orthopedic issues. And when I found out how they figured out their groin pain, it was that protocol, and then it was a hernia repair. And so I'm assuming it's done for a reason, that those are some of the symptomatic cases.
yeah. Um, Here's a question. Is the presence of a cam and pincer abnormality more diagnostic than labral thinning for, I guess, hip disorder?
I would agree with that. The most common type of impingement is a little combination of the two. So basically, CAM is referring to, rather than, it's I think an engineering term, rather than the ball of the ball and socket joint being perfectly spherical, it basically has a bump on it. Like, I often
Uh-huh.
put my knuckle up to kind of describe that
That's
patient.
a good
And
one.
then the pincer, right? And then the pincer is just an extension of the labrum. It uses of the acetabulum. The socket is larger; it covers more of it. And so now, if you have an aspherical ball with a bump on it, moving up against the socket that has a little extension and maybe
Overhang.
turn
Yeah.
down, overhang, exactly, you can get more pinching. You can get more impingement, and I think that can be more suggestive of potential hip joint pain, and specifically from impingement, than just the labral thinning alone.
Yeah. Very good. Um, I see patients with muscle spasm and, well, let me rephrase this. I see patients that come to me with possible hernia and they feel a popping in their abdominal wall. They're like, oh, I felt a pop and I pushed it back in. And
Mm.
it's in an area where there's no way you can have a hernia, like it's subcostal on the
Okay.
side or something like that.
Mm.
And it seems to me what they're having is a muscle spasm.
Mm.
And when the muscle spasms, it's like becomes really tight. You can feel it. You can actually feel it. It's like a ball,
Yeah.
but it's not a hernia. Do you see that? What's the mechanism of that? And then what do you recommend for treating
I
these?
do, not common though. I think because of the type of practice I have, I think if I were set up in the community and seeing people
Oh, you're
initially,
highly
like within,
specialized.
48
Yeah.
to 72 hours of their symptoms, I'd probably see more of that. I certainly saw more of it when I was a physical therapist working
Uh-huh.
side by side with a chiropractor. I certainly saw a lot of that. I think it's a protective response from something else that's going on. So
Okay.
patients always come in often saying, I have a muscle spasm and that's the problem. I say, that's fine. But I think that's a symptom of the problem. And so we need to figure out why your muscle is spasming. And I think it can be anything from faulty postures to kind of bad habits with movement to, and lots of this stuff I think can be spine related.
Got
The
it. Oh,
largest
spine
proportion
related.
of spasms that I see that occur are somehow linked to the spine.
Wow. I have some more questions about that, but here's another question. For Dr. Wyss and Dr. Towfigh's opinion, does the quality and location of pain associated with athletic pubalgia differ from that of the location and pain associated with an inguinal hernia? That's a good
Yes.
question. I think that's a problem that we have is trying to differentiate a sports hernia from a true inguinal hernia in terms of location and pain.
Can I ask you a question, Dr. Towfigh,
Mhm.
on that?
Yeah.
With a typical inguinal hernia, I would assume that symptoms might somewhat be random and may be related to a lot of patterns of the day, life activities. Is that true?
Yes. So most inguinal hernia pain is activity related. So
Okay.
if you're resting and especially lying flat, the pain should go away.
Okay.
Mostly. It's like
Mhm.
over 90% of the time. And then some of the pain is gender based. So the typical pain is groin pain. It can radiate to the inner thigh, testicle, around the lower
Mhm.
back. In women, it can radiate into the vagina.
Mhm.
But you can have these what I call like atypical signs, right? So nausea, bloating could
Yeah.
be a sign. Many patients have pelvic floor spasm associated with their inguinal hernia. So they complain of like painful bowel movements or pain with the full bladder or difficulty like urinary like frequency, painful intercourse. Men have pain with orgasm. So those are kind of side effects of the hernia that you don't usually see with sports hernias. I feel sports hernias are very localized to that muscle group,
Yeah.
with the understanding that you can have tears in the groin where a hernia would be. Those are, I think, the most difficult to figure out is
Yeah.
if it's a hernia or an actual tear. And so for those people where, first of all, you have to be active. You can't just sit around and say, oh, now I have a sports hernia,
Yeah.
right?
Yeah. Right.
So
Right. 100%.
assuming assuming you're a sportsman,
Yeah.
um,
Yes. Yes.
then sometimes I don't offer laparoscopic surgery to those people because then I can't assess if there's a concomitant
Hmm.
tear.
Yeah.
So I had this actually medical student, she's now a surgeon, um, who used to be a professional figure skater,
Mhm.
really bad groin pain. And I said, it's hard for me to tell if you have like, because her hernia was like super, super small, which in some women can hurt. Also, pain with menses makes the groin pain worse in women. But I'm like, you may also have a tear because of, and so that's exactly what she had. She had a super small hernia, which I fixed.
Mhm.
Um, Very disrupted pelvic floor, like that. She had so much scar, especially I said on your right leg, so much scar I had to cut through for the laparoscopic portion of the
Mhm.
repair. And she says, "Oh, well, I'm a figure skater. That's my landing foot, right?"
Right. Right.
So that made sense. But
Yeah.
she indeed had a tear, a fascial tear, which I repaired. But if I didn't have that understanding, a lot of these patients would just, oh, we fixed your hernia, you're fine, go home.
Yeah.
And it was laparoscopic, so you never see the anterior fascia.
Right.
So
Right. Right.
that's where it is.
Yeah, I mean, I personally find that just with athletic pubalgia, other than the occasional in males, some testicular related symptoms, which might
Hmm.
be some referred pain or nerve irritation,
Hmm.
I don't find those other secondary or atypical symptoms you were
Yeah.
reporting. And it also is often fine with your everyday activities. It's truly with sporting activities with a large proportion of if it's a real serious injury to that whole complex of the rectus abdominis and adductor, they might then become painful just, getting up from a chair and getting out of bed.
Hmm.
But if you talk to them, their initial symptoms were only sports related.
Yes. Yeah, especially if they
They
want to
didn't
like
have to completely lie down to get rid of the symptoms. They just had to stop competing at the highest level, or they
higher
just had
level.
to, like a martial artist, they just have to not do one certain kick or takedown.
Yes,
Everything else they could do fine. So I think that
you're
I think
right.
that part of it with the history can be helpful.
Yeah, you're absolutely right. Like they can run, but they can't sprint.
Right.
They
Right.
can they
Change
can
directions might be the
changing
problem, but
directions.
they could
Yeah.
run a marathon with minimal symptoms.
Yeah, yeah, that's very, very true.
When
Yeah,
I see endurance athletes with athletic pubalgia, they ask me if they should fix it, if I can help them rehab through it. I tell them, you know, if you want to also play flag football, you should probably get it fixed. But if you really just want to run in a straight line, you probably don't need to. And I can't tell you how many people have sent me a picture after their marathon and they were like, thanks, doc, you were right. I got through it.
Don't knock flag football. It's going to be one of the Olympic
I
sports in
know. I'm
LA,
in your
LA
area.
2028.
Absolutely. But a lot of change in direction. So don't do that with athletic pubalgia. It'll be hard on it.
The problem with general surgery is they don't understand a lot of this. So if they see someone who truly has a hernia, but it's not a big bulging hernia,
Mm-hmm.
and the imaging therefore is like normal, even though technically it's not, um, they call it a sports hernia, which is really what it really is it's an occult inguinal hernia. That's what I call it.
Got it.
But they call it sports, and then the poor patient follows the wrong pathway towards diagnosis and treatment. Can I ask you about red light therapy?
Sure.
This, what is it and
You
why
take a
do
right turn here. Maybe a U-turn.
well, I mean, I guess it's used for certain strains, right? Muscle strains and
Yeah.
maybe what can you explain it?
So yeah, and for this, I'm tapping into a little bit of my physical medicine and
Yeah.
rehabilitation training, but even more of my physical therapy training.
Okay, great.
I personally have stopped using almost all modalities. You know, over the years, I've been trained in using electrical stimulation and
Mhm.
ultrasound and laser and even shortwave diathermy. Like the number of modalities, physical, you know, for physical
Yeah.
treatment have been out there. I I personally haven't been that impressed with most of those treatments. Um, I have over the past 2 to 3 years taken a deep dive into shockwave therapy, electrocorporeal shockwave therapy, and
Is that the one where you
was
have to go into a
originally
bath?
lithotripsy, and now with
Yeah.
it's a handheld device.
Oh, handheld
Um,
device. Okay.
yeah.
But not like the Theragun.
No.
That's
So
different.
Theragun times like 50 with more focal applications.
Okay.
And I've actually been uh, fairly impressed by the results in the literature that's come along for treating. At first, a lot of it was treating like foot disorders like plantar fasciitis, but a lot of it has been extended into treating a lot of different tendon problems throughout the body. And
Yeah.
the hip and thigh area has responded reasonably well in my practice. I have a couple college soccer players who don't have the time to repair an athletic pubalgia or sports hernia,
Yeah.
and they're hoping they can get by with a backup treatment. And
So is it a handheld device?
it is. It
Like
is.
the Theragun?
Yes. It'll look similar, but the what you deliver feels very different for the patient.
Hmm. It has a point to it?
Yeah, I can.
Oh, you have one in your office? I love it. Show it to, oh, it's like a probe.
Yeah.
Got it.
You have all different tips for application. There's actually two different types of shockwave called radial and focus, and the research for orthopedic application is really just evolving. But I'm more impressed with this than the 20 plus years of using different therapeutic modalities.
There's a question about the core.
Mhm.
Um, this poor lady, she says, Dr. Wyss, I had a pedicle tram flap with lots of abdominal wall repairs. And some of these tram flaps, when they go awry, um, or flaps, I should say, not just tram flaps, there's denervation as well,
Mhm.
as they lose their core.
Got it.
What do you recommend for those of us with no core? To make
Find a
it,
good physical therapist.
yeah,
That's what I really think, because that's where some PTs are getting into using ultrasound just as like a biofeedback to show people what they should be
oh,
activating. There's biofeedback devices. There is electrical stimulation. I think some of these like therapeutic modalities have a certain role when you're trying to retrain muscles, but really you need somebody who's willing to be patient and help you kind of find it in whatever
yeah,
way you find it. And then you have to find it before you can train it. And I
Some,
think most cases, even in a situation like that, there's enough core musculature that you can find some help and you can find some of these muscles to train them again.
some people who have denervation injuries from surgery, either from a flank hernia, flank incision, let's say for spine surgery, sometimes they injure the nerves, kidney surgery, or these abdominal wall flaps for breast reconstruction. They ding a nerve, so you get one dermatome of denervation. Is there any hope in those patients? When you're talking about physical therapy, do they bulk up the rest of the muscles to make up
Yeah.
for that one adjacent muscle, or how does that work?
I think so. I think it's far more challenging if you have less muscle to be able to recruit, or you're also dealing with chronic pain and scar tissue and everything else. But I still, I don't think I've found anyone who couldn't train some of these muscles. They might be starting at a really low level, but I still think it's possible
Yeah.
to progress.
So as hernia surgeons, we're struggling with regard to what kind of therapy we should be offering patients post-operatively. Most general surgeons, they take out a gallbladder, colon, whatever the situation is. Patient goes home, there's no physical therapy involved.
Mhm.
On the opposite side, most orthopedic surgeons and spine surgeons, there's always some type of physical therapy involved post-op.
Yeah.
So do you think that abdominal wall surgery and groin surgery should have a physical therapy component afterwards? And
Yeah.
is it focused on like strength training or scar, or what do you think about these?
I I think that's a little bit tough for me to answer from my perspective. Um, just because I think it could be all of the above.
Mm,
I think if you're not really worried about a muscle being able to be trained or some sort of complication related to the surgery, they should be able to basically be guided through some exercise to get back to it. But I think the problem is that we don't always have the time. And some of us don't have the comfort just providing some basic exercise counseling.
mhm. So
But
when someone has, let's say, hip surgery, what's
Mhm.
the purpose of physical therapy? Is it to strengthen or to reduce scarring where the surgery was performed?
I think that's all the above.
Okay.
I think that in most cases, early mobilization does lead to some better outcomes.
Mm-hmm.
I think that then it was certain surgeries, anything related to FAI, the hip, we often see a combination of gluteal muscles that shut down. Some of the therapists often call it glute amnesia. These
Yeah.
are just
Gluteal.
things people
My
can't find
trainer
if you
calls it
can't
gluteal
train them.
amnesia.
Yeah, exactly. And then the core shut down a little bit. So I think in certain situations, there's certain muscle groups that will have their challenges. So
Okay.
having guidance on how to find and train those muscles are important. And then I think some of it is also offering the appropriate supervision so someone doesn't hurt themselves. So they're guided through the phases of rehabilitation. Not everyone knows that you want to get good, you need to control pain and swelling first, then you need to get good motion back, then you need to find those muscles and build strength. If you don't go in the right order, things get messy. And so I
Mm-hmm.
think that's where that's where really a physical therapist can shine and really make a huge difference in the outcome.
There's a group out of Ohio, the Ohio State University.
Mhm.
Dr. Ben Paulus, he was one of our guests. He's really into trying to understand this. So he has a whole lab dedicated towards um, the physicality of abdominal wall, core, and then surgical, how the surgery changes it. So he's worked with his physical therapist and came up with a physical therapy for early post-op rehabilitation after abdominal wall reconstruction.
Mhm.
That's available free on their website. It's the uh, Ohio State University website, and also the achqc.org. It's free for patients. You can just go into the patient section and look at it. It's pretty good. You know,
Nice.
a lot of different, it's basically core based.
Nice.
Um, but patients always ask me, and I feel really embarrassed saying we don't really have, like, I do their hernia repair in the groin, especially. Like, oh, do I need, so what do you do for can I get a physical therapy referral? I'm just like, yes. But we don't have anything coordinated.
Right.
I wish
I
we
think
did.
that, lots of these things happen from just good collaborations, some multidisciplinary care. I mean, maybe there's a role, but maybe there's a limited role. And I think, working with the right PTs, you can figure that
Yeah.
out. Sometimes there's just need for education. And sometimes I think there's a need for, a very supervised formal physical therapy program.
So one of the viewers here is from New York, and she's asking for physical therapy recommendations. So for people with core dysfunction,
Mhm.
um, do they go to any specific physical therapist, or how do they find a good physical therapist? Are there questions they should be asking?
Yeah.
I assume pelvic floor physical therapists won't be addressing core, or am I mistaken?
So yeah, there's some overlap there. I
Okay.
think if I think if you're really training the core, you can't ignore the pelvic floor, but then there are uh, physical therapists who will focus on pelvic floor therapy and pelvic rehab, and that's kind of a different subspecialty of PT.
Yeah.
But I really tell patients just to ask around in your community. You don't always want to be traveling long distances to find a good PT, and you should be able to find someone locally, and even asking a primary care physician usually know who's providing good care. And then I think my advice when you pick a facility is that you should feel like you're getting some individualized care.
Yeah.
You shouldn't feel like you're being passed along to different therapists. You should not feel like you're doing the same exercises that a number of other people are doing. And there should be some one-on-one time. There should be one PT who's in
Hmm.
charge, even if there's others helping out. I think that's a big part of it.
Very good. Thank you. Here's a question that was submitted. I have both C6-7 cervical and L5-S1 lumbar hernias. I also had incisional hernias. Is there any relationship between abdominal and spine problems? I mean, they're all hernias.
They sure are. There's a common word and thread.
Herniated disc and abdominal wall hernia. It's the same.
Um, I would say I'm sure there's some indirect connection, but I'm not aware of there being any really like landmark paper that says if you are prone to symptomatic disc herniations
Uh-huh.
in the spine, that you're then prone to other hernias. I don't know if you're aware of anything different.
No, and it's not a college. Is it a collagen disorder in the spine? I don't think so. I don't know. I know it's
Well,
genetic,
yeah, I
both of them.
mean, the intervertebral disc is so, but it's also, I think, just very human. It's just
Mhm.
very common to have changes to the spine and changes to the disc. And in many regards that even a hernia, a disc herniation in the spine can be asymptomatic
Yeah,
in large groups.
true. And sometimes people come to me with a bulge in their belly, because they're told it's a hernia, but it's not a hernia. It's actually a nerve impingement. Usually I've mostly seen it like lower thoracic, upper lumbar.
Hmm.
Um, and it's usually a bulge kind of anteriorly as opposed to the flank.
Hmm.
Or like anterior, but also like around the anterior and flank. And it's linear.
Hmm.
And you get your spine decompressed and the bulge goes away,
Interesting.
assuming you don't wait too long.
I
Yeah.
did not think I was going to learn something about spine care on this. Amazing.
Yeah, I have a couple spine doctors that help me out with those. And there are others that think they're like, that doesn't happen. There's no pain. I'm like, I know there's no pain, but they're presenting with a muscle weakness. It's not a
Yeah.
hernia. But yeah, it's
Fascinating. Yeah, I
basically
mean, that's the innervation of the lower thoracic spine.
yeah,
Fascinating.
abdominal bulging.
Yeah.
Yeah, so I'm here to teach.
I
We're all
love
here to learn.
Yes, we are. Love it.
Let's do one last question.
Sure.
How dangerous is cervical manipulation of the neck?
Question. So I do refer to chiropractors quite frequently. I think that cervical manipulation does have some risk beyond manipulation of the thoracic or lumbar spine. There are the rare case reports of vertebral artery dissections. They do tend to actually be in younger rather than older patients more commonly. I think part of that might be how far the neck could go if you were manipulating it.
Oh, so it just completely
you think
like
about
an
a
Indian
15-year-old neck
rub of your
versus a
vertebral artery.
75-year-old neck, how far it can go, right?
Wow.
But I think with good technique, that is not a common problem. I think
Okay.
that is very much a one-off, a very rare complication. And so good judgment, good chiropractic skills, I think it can be safe and effective.
Well, this was very fun.
Yeah, I had a lot of fun too.
Did you see how soon the hour went by?
So fast.
So fast. Except it's 8:30 p.m.
Except
your
it's
time,
late
so I
here, and
apologize.
it went from there being some daylight to it's now dark.
Oh, but congratulations on your new puppy.
Oh, thank you.
That's very, very cute.
He's wonderful.
Oh. Well, that's it, everyone. Thanks so much for joining us. And thank you, Dr. Wyss, for your time. I learned a lot, and I hope to share more patients with you. And everyone, appreciate your time here. We have another great guest next week, and I hope to see you again. Go to YouTube, subscribe. You can watch all of these videos on your own time, share it with others, or listen via podcast. And don't forget to follow me so you'll know who's coming on every week as we enjoy talking about hernias on Hernia Talk. Thank you.
Thanks so much for having me.
Thanks. Take care.
Have a great
Bye.
night.